Okay, everyone, well, here we are doing a wrist ultrasound. Actually, we're going to have a look at the wrist as well as the fingers. So, quick anatomy revision. Okay, this is volar or palmar aspect. This is the flexor retinaculum here. That forms the roof of the carpal tunnel. So if we take that off, that little sort of osseous tunnel in there is where our median nerve runs. So we're going to be looking at that. It's also where our flexor digitorum superficialis and profundus tendons run. It's also flexor pollicis longus, so to your big thumb, down to your thumb, right? And over the top of that flexor retinaculum, we have the palmaris longus tendon. So we're going to look at all of those. Down in our fingers, we've got the volar plates or the palmar plates. So we're going to look at those. We're going to look at the flexor digitorum superficialis and profundus as they extend down our finger. We're going to look at the pulleys, the A pulley, the A1 and the A2 pulley, and maybe the A3 pulley. We're going to look at the dorsal aspect of the wrist. So the bump here that we've got on the radius or the distal radius, that's Lister's tubercle. That separates compartments 2 from compartments 3 in the wrist. So we're going to look at that. We're going to look at the other of the extensor compartments within the wrist. We're going to look at the scapholunate and lunate triquetral ligaments in the carpal bones. We're going to go out here on the medial aspect of the wrist and look at the triangular fibrocartilage. And we're going to look at the ulnar collateral ligament of the thumb. So there's a little bit to get through, so we'll get started. So we can start with the volar or the palmar aspect of the wrist. It really doesn't matter. Oftentimes wrist sonography, the clinical request is query carpal tunnel syndrome. So we might as well start with that. So carpal tunnel syndrome refers to the condition whereby the median nerve is compressed, right, for whatever reason. Or say the median nerve is irritated. It may not necessarily be compressed, it's irritated. Now, whether that be through trauma or infection, ganglion, inflammation of the tendons, so tenosynovitis, it doesn't matter, right? So whatever is causing this little median nerve in here to be angry. So here is our carpal tunnel. We can see the osseous bones here. We can see, if we go where the little finger, we've got the pisiform out here, and then we've got the scaphoid out here. So remember, we have a proximal and a distal carpal tunnel. We measure the median nerve in the proximal carpal tunnel. So if we measure around the nerve there, so here's our nerve, and this we would measure around the nerve, and it shouldn't be more than about 0.1 centimetres squared. Right? Now, I always look at the nerve not just in static images, I look when the patient's moving. So if you can just wriggle your fingers, and this is what we should see. See the flexor tendons under here moving away nicely and the median nerves just rolling around. That's perfectly normal. People that have had carpal tunnel surgery are prone to developing adhesions around the median nerve. And so when they wiggle their fingers, the nerve doesn't move normally. You can still get it without having had carpal tunnel surgery, but it's just more likely if you've had carpal tunnel surgery. Now, always put the colour on, see if there's any increased vascularity. No, here's perfectly normal. Got our ulnar artery pulsating away over here, so that's all good. Now, you can have more than one median nerve. You can have a bifid median nerve, so you can have 2 median nerves, even 3 median nerves down in the carpal tunnel. That's just a normal variant. It really doesn't matter. What does matter is if when you put the colour on, between the median nerve branches, so if we had 2 little median nerves, right, sitting in here, if you can see an embryological remnant called the median nerve artery. If you see that, then that is a higher incidence or associated with a higher incidence of carpal tunnel syndrome. Also, it's the sort of thing the surgeon might like to know about before they go in there cutting things. So remember, the way they treat carpal tunnel syndrome is by cutting the flexor retinaculum. So speaking of the flexor retinaculum, that forms the roof of the carpal tunnel. So here's our flexor retinaculum over the top. It's very thin structure, looks like a bursa, so you've got a white line, black line, white line. And remember, that forms the floor of Guillon's canal. So we've had a look at the carpal tunnel. Over here, we've got Guillon's canal. So this is where the ulnar nerve runs. We can see the ulnar nerve, we can see the ulnar artery and the adjacent tiny little ulnar veins, which I'm compressing through there. And over the top of Guillon's canal, we have the palmar carpal ligament. So that forms the roof of Guillon's canal. So Guillon's canal is a bit like the carpal tunnel. It's just not one point, it extends over an area. So make sure if you're looking at the ulnar nerve that you scan through Guillon's canal. And once again, we're looking to see if anything's compressing the nerve. People can have fracture up the bone up here, the carpal bone, and that can impinge upon the nerve as well. So look at all of that. Now the other structure that we spoke about was the palmaris longus tendon. That doesn't sit within the carpal tunnel. That's this fine little structure sitting up here that attaches to the palmar aponeurosis in the hand. Right. Then we have flexor carpi radialis sitting out here. We can go longitudinal on that. You can see the flexor carpi radialis coming down. And then if we go over to the other side, we've got flexor carpi ulnaris. That's sitting up here. We'll just go longitudinal on that because you can see the tendon fibers better in longitudinal. This flexor carpi ulnaris. So if it's on the ulnar side, it's flexor carpi ulnaris. So flexion, ulnar, flexor carpi, carpal bones, flexor carpi ulnaris, and flexor carpi radialis on the radial side. The other structure that we have down in the carpal tunnel is the flexor pollicis longus. So that's the tendon that goes to your thumb. So if we just wiggle the thumb, right, oops, here's our flexor pollicis longus wiggling. So turn through 90 degrees, and we can just wiggle, there it is, look at that, that's lovely. So the flexor pollicis longus has its own sheath. So if you had inflammation of the sheath or a synovitis, you can get a hypoechoic halo surrounding that tendon. Now, staying on the volar side, we've got our scapholunate ligament. Right? So there's multiple other ligaments, but the ligament I want you to focus on is the scapholunate ligament. It's not hard to find. Right? We can see our distal radius and ulna. The scapholunate ligament is on the radial side because that's where the scaphoid bone is. And the scapholunate bones are in the proximal carpal row. So you can come down the bones of the distal radius and ulna. When they disappear, we're in the proximal carpal row. If we move to the radial side, we can go, okay, here's our scaphoid bone, here's our lunate bone, because it's the proximal carpal row, and I've moved to the scaphoid side or the radial side, and there we go. Over the top is the volar aspect of our scapholunate ligament. So your scapholunate ligament is an important stabilizer in the wrist. If you fall over and land on your hand, this is a little ligament that gets torn. Sometimes people go, I've got a sore wrist, but then they just ignore it, and then years later they'll have a little ganglion appear here. That's through a tear in the scapholunate ligament. So that's looking at the volar aspect of the wrist. Now if we go down and have a look at the fingers. So all the fingers are much of a muchness. I just like to scan this index finger because it's easier to see. So this is our metacarpal head. It's the base of our proximal phalanx. That's our volar plate. Right, that's what it should look like. This nice echogenic sort of triangular structure that helps to prevent hyperextension of our fingers. Right. It also forms part of the joint capsule, so you tear that, you'll have joint fluid leaking through. There's articular cartilage. Nice hypoechoic, smooth articular cartilage. At the base of this metacarpal is where you would get early rheumatoid arthritis typically forming, so you would look for erosive change in here. And over the top we've got our flexor digitorum superficialis and flexor digitorum profundus tendons. They're hard to separate in a longitudinal plane, but if if we just give our finger a wiggle, there you go, you can see the flexor tendons moving. Now, over the top of the flexor tendons, we have pulleys. Pulleys hold our tendons adjacent to the bone so that when we flex our fingers, the tendons don't pop up. Pulleys are tiny little structures, right? They're very small. So, if we look here, this is the A1 pulley. So you have your A pulleys and your C pulleys. A for annular, they wrap around. C for cruciate, because they're cross-shaped. So our A1 pulley through here. So when we flex and extend our fingers, the tendons have to pass under that pulley. Then we go up into our middle phalanx, and then you have the A2 pulley just sitting in here. And then we come down to the proximal interphalangeal joint. Here's a volar plate again, nice smooth cortical surface, nice hypoechoic even articular cartilage. Flex and extend our fingers. You can see the tendons moving, beautiful. And there's our A3 pulley down here. So they tend to be the ones that tear, A1 through to A3. Right? Now, the flexor digitorum superficialis tendon doesn't extend all the way to the distal phalanx. That attaches to the base of the middle phalanx. So what you're looking for is you get to the base of the middle phalanx, and then you just slide your probe medially and laterally, and what you're looking for, I can see is just there. Sorry, we'll try and get rid of that air. Freeze that image there. And here is the medial branch of the flexor digitorum superficialis coming down and attaching to the base of the middle phalanx. And you see the same thing with the lateral branch, because the profundus perforates through the superficialis. And then what's left is the profundus tendon, and that goes down and attaches to the base of our distal phalanx. Here's the profundus. So that's important to know, because if you're wondering, is the flexor digitorum superficialis torn or the profundus torn, you can sort of figure it out based upon what the patient can do. Because the profundus is the only one that goes to the distal phalanx, if the patient can't flex their very distal phalanx, then they've torn their profundus tendon. So if we turn the hand over, now we're looking at the dorsal aspect of the wrist, and we've got 6 extensor compartments within the wrist. So these are hard to remember, right? They really are. So if we start over on the side of the thumb, we have compartment 1, and that extends to compartment 6 over to the little finger. So in compartment 1, we have adductor pollicis longus and extensor pollicis brevis. So they go longus brevis, longus brevis, longus the tendons. So if we turn the hand on the side, look in compartment 1, is adductor pollicis longus and extensor pollicis brevis. This is what they should look like, right? Just normal looking tendons. So we'll narrow our focus down a bit. If we go longitudinal on that, we can see the typical tendon appearance. And then if we move the thumb, we can move the tendons. So that's all normal. So this is where we get to Curvain's tenosynovitis. So thickening of the sheath and tendons in compartment 1 of the wrist. So there's compartment 1. Now, if we continue to move to the dorsal aspect of the wrist, I'll try and scan this left-handed so you can see. So just in here we have a bump on the distal radius called Lister's tubercle. So that's, if you remember, that's this little bump just sitting in here on the distal radius, Lister's tubercle. Lister's tubercle divides compartment 2, right, so extensor carpi radialis longus and extensor carpi radialis brevis, from compartment 3, extensor pollicis longus. And then If we keep going, there's compartment 4 with our extensor indicis and extensor digitorum. And just in here, you can't really see this branch of the radial nerve. We continue to move across to the ulna. We have extensor digiti minimi going to our little finger, and extensor carpi ulnaris. Now, extensor carpi ulnaris is an interesting tendon because it doesn't have a tendon sheath. So you're not going to get that halo around it with tenosynovitis. It does have a paratenon, so that can swell and become hypoechoic. But when you're examining extensor carpi ulnaris for issues, stay on it, what you're looking for is as it comes down and inserts, you're looking to see echogenic foci here, calcific change in the extensor carpi ulnaris. So just be aware that extensor carpi ulnaris does not have a sheath around it. Now, talking about our scapholunate ligament again, easy to find, right? We know that it's on the side next to the thumb because that's where our scaphoid is. So what we do is we find compartment 4 in the dorsal wrist, the compartment with all the big tendons. We come down, so here's listus tubercle, so we're still in the distal radius. We scan inferiorly until that we lose our radius and ulna. We move over to the radial side, right, and we know that we've got our scaphoid bone here, our lunate bone here. Stretching between them, we have our scapholunate ligament. And then if we go over towards the little finger or the ulnar side, we have our lunate triquetral ligament stretching across here. So the way you find them is just knowing the anatomy. Come down the distal radius and ulna, identify compartment 4, continue scanning inferiorly until you come to those proximal carpal bones. Move across to the radial side, you've got scapholunate. Move across to the ulnar side, you've got lunate triquetral. Now, always examine in longitudinal and transverse, and remember the extensor retinaculum over the dorsal aspect of the wrist looks quite thick, and that's perfectly normal. Don't go calling this a thickened retinaculum. We can flex and extend those fingers and everything just moves freely. Now, staying within the wrist, you've got what's called the triangular fibrocartilage complex. The complex term is tacked onto it because it refers to everything in that area. Really, what we can see is the triangular fibrocartilage. So it just looks like the meniscus or in the knee or the labrum in the shoulder. So if we go to the medial aspect, I like to look at in the coronal plane, right? And the triangular fibrocartilage is like a spacer in our wrist. However, we can tear it. So look on the medial side, and what you're looking for is this whole area through here. This area is the meniscal homologue of the triangular fibrocartilage. And what you're looking for is if there's any fluid tracking up through it, indicating a tear. So I like to radial and ulnar deviate the wrist, looking for fluid coming through. Last thing we're going to look at is the ulnar collateral ligament on the thumb. So this is where we can get what's called a Stenner's lesion. So that's when this ulnar collateral ligament is torn, and then the palmar aponeurosis slips in through that torn ulnar collateral ligament, thereby preventing healing of the ligament. So it's just on the ulnar aspect of the thumb. How did we get to it last time?
Was it like that?
Like that, yeah. That's right. So we're looking just in this area through here. So let's just adjust these imaging parameters. So we'll decrease our depth, bring our focal zone up, increase our gain, and increase our zoom a little bit. Sitting in there, roll that back, is our ulnar collateral ligament going across here. over the top we have our palmar aponeurosis. So that can slip in if this ulnar collateral ligament is torn. So we can stress that joint. Now you shouldn't stress it if you suspect this is torn, because you can then cause the palmar aponeurosis to slip through the tear, meaning the patient would need surgery. But in this case, we can stress that a little. You can see how the joint moves a little, but not too much, so that's perfectly normal. Okay, thank you.